All right, good afternoon and welcome to our webinar, Seizures and Sleep, What You Need to Know. My name is Rachel Bohr and I'm Enzo Data's Senior Marketing Director. All right, now I'd like to introduce Amber. Amber Haas, REEGT, REPT, RPSGT, is the Sleep Center Supervisor at Sanford Health Bismarck Sleep Disorder Center and has over 15 years of experience in sleep and EEG. Amber is on the ASET Volunteer Leadership and Development Committee and is the Education Chair for CSET. She is also the President-elect for the Montana Sleep Society. Amber has a passion for education and presents at multiple sleep and neuro conferences every year. We are very excited to have her presenting for us today. All right, and now I'm going to pass over the presentation to Amber. So go ahead and take it away.
All right, hello everybody. So we're going to talk about something very near and dear to my heart, which is seizures and sleep. As someone who works in both fields, I do get a lot more on the neuro end than some people that haven't studied the EEG world, and this can be kind of tricky to pick out. So we're going to go through all that fun stuff. So our objectives. Today we're going to talk about understanding how seizures actually impact sleep. We'll go over the different types of seizures and discharges, those weird things we can see. You're going to identify what a seizure looks like on a PSG, as well as what do they present as. Sometimes seizures come out of nowhere and they present like you wouldn't expect. Most people assume a seizure is going to be those, what they call grand mal, what I refer to as tonic-clonic, your big shaking full body, but they can be extremely subtle. So we're going to go through some of those. And then at the end, we're going to talk about safety. What are those things that need to take place if someone's having a seizure in the sleep lab? What policy should you have in order? All that fun stuff. So let's start with some statistics. 3.4 million. That's how many people in just America suffer from seizures. 2 out of 5 Americans who have diagnosed and treated seizures but continue to have seizures on their treatment. 40% of epileptics are how many patients have seizures and also have sleep apnea. It's a huge correlation, and it's not always noted between the two. As we'll go through and talk about sleep issues and people who have seizures, you can have a lot of the same symptoms. 150,000, that's how many new seizures diagnosed every single year. Not everyone who has seizures has epilepsy. Not all epileptic discharges are seizures. So we're going to go through, wrong direction. We're going to go through all those little things. A seizure is an abnormal, organized, and evolving burst of cortical activity that interrupts the brain's usual function. A lot of people, when they think seizure, they think things are going crazy and it's very out of control. But as you can see on this screen, it's completely the opposite. Everything's firing exactly the same, straight across the board. So if you're looking in that center part where all that fun abnormal activity is, you can see it doesn't necessarily look chaotic. It looks extremely rhythmic. And that's a huge sign of seizures. We're looking at for rhythmicity. We're also looking for the length. We need to officially call something a seizure. It needs to be at least 10 seconds long. Does that mean something that's less than 10 seconds isn't abnormal? No, it just means it's not classified under a seizure classification. So how do seizures affect sleep and sleep apnea? Excessive daytime sleepiness, the one most of us hear with our sleep patients, is actually one of the most common complaints of epileptic patients as well. Patients have fears associated with sleep, such as having seizures within their sleep. And I'm going to tell you guys how prevalent that really is. A lot of seizures, their only presentation is while they are sleeping. Frequent arousals, something we see both in sleep and in EEG, there we go. Sleep patients, of course, they arouse from snoring or limb movements or apneas. Seizure patients can be woken out of sleep from seizures. And if they have apnea too and they know about the apnea but don't know about the seizures, it can be extremely hard to catch. Patients with epilepsy have a higher incidences of anxiety and depression compared to the normal population. These disorders are frequently also being associated with insomnia. Again, our sleep world, those are things we hear every single day. So it's making sure we're looking at those differential diagnoses as well. Untreated OSA can result in a lot of nocturnal arousals, respiratory events, oxygen desats, all these fun things. What you may not know is things like that also can trigger seizures. Seizures can be brought on by things challenging the brain. So lack of sleep, lower oxygen, frequent arousals. When we are doing an EEG, one of the things that we try really hard to do is get our patients to fall asleep and then to wake them up at the end of the study. In those transition stages where someone is falling asleep and when someone is waking up, give a high propensity to actually see abnormalities come out. They may not have an actual seizure, but we might see what that abnormal discharge is. Things, when people aren't having seizures, in between their seizures, they have what we like to call interictal discharges. Most do, not everybody, but majority. And that's a way to kind of get those to come out so we can see if we're actually looking for a seizure or if it's something else. It's also worth noting that many people with epilepsy have undiagnosed sleep apnea. As I've been talking about, all those characteristics that we see in sleep apnea, if someone's epileptic first, they might attribute all of those to be associated with their epilepsy and not with their sleep apnea. A lot of the sleep apnea can also make seizures worse because of all the things that were listed above. So it's a very cat and mouse game here, but they go hand in hand. Good sleep will help lower seizures. Poor sleep will help increase them. So this is a small study they did with refractory epilepsy where they had evaluated those interictal discharges I was talking about, so those things that happen in between seizures. And they found that the more severe OSA correlated with a higher spike rate. Treatment of OSA resulted in a decrease of those discharges. During waking and during non-REM sleep, improve sleep architecture and decrease seizures. So we're not only helping them get less seizures, we're helping improve their sleep. So we're going to go over these types of seizures and what I was talking about. First one that you've probably heard me say already multiple times, discharges. They're short bursts of transient activity. They can be focal or generalized, and they generally last 2 to 3 seconds. Now, when I'm talking about this, I'm meaning across the screen, you'll see this really weird little, could be a half a second, just sharp shoot out of nowhere. And it's like, okay, but then you don't see it again. That would be a discharge. Or you might have a little spike and wave, which you would be able to pick out. I'm going to show you what they look like in a little bit here. Now, between discharges and seizures, there's another thing called BIRDs, which are brief, ictal, rhythmic discharges. These are those ones that they're longer than a discharge, but they did not hit our seizure requirement of being 10 seconds. But what we're looking for is rhythmicity. We're looking to make sure there's a field, so you want to make sure it's in more than one channel. Seizures will not just show in one channel. Discharges will not just show in one channel. There's always a field. And then you're also watching for that time. And then, of course, seizures, if we're going into a formal diagnosis or formal definition, they're runs of rhythmic repetitive activity consisting of sharp and or spike waves, possibly slow waves, duration of greater than 10 seconds. When we get into this and I talk about how long seizures last for, anything over 5 minutes is extremely concerning, even with a known epileptic. If a seizure goes more than 5 minutes, it's going to take medical intervention to get it to stop. So just want to make sure everybody's aware of that as we move forward here. Seizures. So episodic nocturnal wanderings. Generally, we would view that as a parasomnia. Someone sleepwalking or the unintelligible speech, so they're sleep talking. A little kid wakes up screaming, sounds like a confusion arousal. Violent behaviors, sounds like REM behavior disorder. Every single one of those could also be a seizure occurring. Nocturnal frontal lobe epilepsy, which is mainly characterized by phenotypes of paroxysmal arousals with brief hypermotor movements. What this is going to look like is those motor jerking. That's what your sleepwalking is going to look like, all of that sort of thing. And then I include this last one in here because I find it very interesting. Supplementary sensory motor area epilepsy. It's a very distinctive subtype. A lot of times they call this one the fencer. A patient will literally get in a fencing stance during the seizure. And then they generally have a speech arrest or a loud vocalization. And then they'll start flailing like you would if you were waving around a sword. So it's just a very interesting seizure type. And it kind of shows that seizures come in all different shapes and sizes. So at least 2/3 of seizures occur between 8 p.m. and 8 a.m. And I'm talking worldwide. Most prevalent time for a patient to have a seizure is during their sleep cycles. 12% of epilepsies cause nighttime seizures, mainly exclusively. So 12% of all epilepsies out there are exclusively nocturnal. Lack of sleep leads to more frequent seizures. I do tend to repeat myself because it's very important to understand that correlation. In children with benign Rolandic epilepsy, 70 to 80% of their seizures will occur while they are sleeping. Least likely stage for you to have a seizure in is REM. Generally, because we're talking about nocturnal seizures, so they're looking for the nocturnal brainwaves where your REM brainwaves are so close to your awake brain that it's less likely to occur in those states. So, focal seizures compared to REM sleep. So if someone is having a seizure in a focal seizure in stage, they're more like, gosh, I got to get my words here, guys. So if someone's having a focal seizure, they're 87 times more likely going to happen in N1 than in REM. 68 times more likely in stage 2 and 51 times more likely in stage 3. Now, if we're on the generalized form, generalized are much less large as far as how more often they're going to have them, but 3 times 1 more likely to have it in 1 than REM, 3.13 times more likely in 2 than REM, and 6.59 times more likely to have it in N3 than in REM. So it just goes to show how much more prevalent these show up in our deeper, or not our deeper, in our sleep stages than they do in that one that correlates most likely with an awake brain. Types of seizures. So, like I said earlier, when people think grand mal, I say tonic-clonic, which is a generalized presentation. It's self-explanatory if you think about it. Tonic, muscles tense up. Clonic is jerking. A big tell with your tonic-clonic, if you do see someone doing this, everything on the body should be rhythmic and shaking at the same rate and speed. They should not be flailing. Flailing for us in the neuro world tends to mean more of what we would call a non-epileptic seizure, so more of a mental thing than it would be an actual seizure. Just something to point out there. Jerking, so limb jerks following an arousal. So could potentially in our world look like a hypnopompic jerk. Could be, but it could also be a seizure or at least a discharge depending on length. Staring. This one, more than likely, you're going to see this in the kids, way more prevalent in your younger children between 2 to 7, have what's called absence epilepsy when they are drowsy. That's why we sleep deprive some of our EEG patients. But if patients come into us, they're tired, they're not sleeping well. So in their drowsy state, you might see them have a conversation with you and just stop talking and pick right up where they left off and keep going. That can be a seizure. It's very distinct in how it presents both visually and on the screen. It's a 3 per second spike and wave. It's beautiful to see when they do come across the screen, but it's definitely a different presentation than anything physical we're used to seeing. So I'm going to show you some of these fun things. Right at the top, you can see where my arrow is. That is the start of this frontal lobe seizure. You can see all that sharp activity coming through there. I do always point out here, this one started with a central apnea too. So they're holding their breath. We're probably getting an oxygen. Oh no, that's not doing it there. But they're holding their breath at the same time as having this event. Technically, I don't know if they're correlated here because they started holding their breath a good 10 seconds before this event started, probably 20 seconds. And then the event is occurring on the end of it. We're not seeing an oxygen desat yet. So they could have sleep apnea and epilepsy and have nothing to do with one another. But this is what a frontal lobe seizure would look like on your EEG, or the EEG portion of your PSG. So this one is what we would call a subclinical seizure. I'm sure everybody can see, right, that dramatic start where we get that big sharp wave, and then your waves look very different coming over. This patient is what we would call subclinical because they are having no physical presentation along with this abnormality coming through. So you see this person seizing, if you were watching their video, nothing would be changing about them, but their brain is not a happy camper. Now this one does come with a clinical presentation. So again, we have a generalized seizure. If you can see, I'm trying to look at my little buttons here, at where we've got that arrow is where it's going to start. You're going to start to see some sharp waves and activity come through, and then you see that burst through a little over halfway over the page. What I'm looking at here as far as clinical presentation, you can see that EMG picked up. So all of a sudden they're tensing, they've got muscle movement. Those are things we'll see when someone is having a clinical presentation. You will see muscle come through. All right, here is another one. This one really gives you an idea of when I say a field and evolution. The seizure starts right after where it says up at the top, you'll see EEG onset, and then you see tonic-clonic seizure. As you watch, those waves get bigger and bigger and bigger and bigger. That's an evolution. It's getting bigger, and then as it comes down, it will get smaller. This one did start with acentral apnea, meaning its brain was too busy having this seizure to tell you to breathe. One of the reasons some people have breath holding spells during seizures. As well as the field as well. At first, it can be a little hard to see, but then all of a sudden, as you get a little over halfway over the page, you can see it is generalized all the way across. And as it starts to come out, your occipital channels were the first to let go of that seizure as it's coming down. So, talk seizures. Now let's talk discharges. What you see on this screen is a lot of sharp activity, but these are not seizures. These are independent. This is what I would call a multifocal discharges because they are occurring in different places at different times. If they were occurring at different places but at the same time, that would just mean somewhere within there is your focus. But in here, this patient probably has multiple foci included with their seizures. So if they have one, they could have more than one type of seizure. We might be seeing a generalized and a focal occurring at different times. I'm going to get into one of my patients here. This is one of my favorite ones. If you look at where I have that discharge, at first it kind of looks innocuous. Like you're looking at it, it looks like, okay, they just had a really big K complex and some sleep spindles. But I took it and I broke it down so I could see it up close. As you can tell pulling in, this is actually a dual spike coming through there. It's not our normal K complex shape. It's not spindles attached to a K. It is two distinct sharp waves popping through there. And this patient, thankfully, we knew ahead of time had known epilepsy, so we knew to watch for these things. Now, another one on them, they did this. This might grab your attention, but it almost looks like bruxism, like just very short bruxism because their chin was pulling through. But again, when I went and broke it down, we were talking a polyspike formation. So you can see how easy it can be to overlook all of this because it looks like bruxism or it looks like a spike wave complex. It'll look like an arousal. That doesn't mean that's what it is. So it's making sure you use those investigative techniques as well. Now I'm going to pull up an EEG just because this is an interesting type of epilepsy I like to pull up. This person has occipital. Since we do, and which is mainly seen, as you can see, this patient was asleep before it started. You can see that. So in their sleep, they have occipital seizures. It was a really cool presentation. I like to show this because you can really see that what we call polyspike, so those double spikes right at the top of that slow wave. Now this one can be a little harder to see. I just think it's very interesting. This is one patient having serial or multiple studies. The first one is an EEG. So this very first one where it says A, so we can see they have a poly spike and wave presentation. So we're getting double spikes and we're getting big waves, but they're short. Well, then they came in for a sleep study and all of these little areas were actually marked as arousals rather than marked as the discharges that were actually occurring. And we're looking at it in different stages as well. The top B is, if I remember, yep, that's N2. C is your N3. And then well, 3, 4. And then D is in REM. So they even discharged in REM, which is extremely rare compared to the other stages they can discharge in. Now let's pull up this fun one. So I was talking about earlier about that absence having a very specific presentation. It's another reason I pulled an EEG in to show you. This is 3 per second spike and wave, and I got it scrunched up so you can see it in more of a sleep screen. On the EEG end, we look at things in a 10-second screen rather than a 30-second screen. So for us, it's very blown up. But when you're looking here, it can look very, the scrunched is the issue. When you scrunch these screens together, it can look like arousals. But as you can see here, that rhythmicity that I was talking about, you can really see it. And it is, again, you can almost see it. It's a little hard, but that spike followed by a slow wave, spike followed by a slow wave. This is another one I pulled that this actually got my EEG techs. They're running their study. This to them looked like a sleep component. until you put two and two together and realize it's not just in a specific channel, but it's generalized. And there is a spike component, not a K complex with, a K complex followed by sleep spindles. There we go. So this is even on a stretched out screen. So I can only imagine what this would look like if we had scrunched it down, because it would have looked like just a K complex. This one is a very recent one that happened in our lab. This looks like an arousal. Now, it looks like they're awake, they're moving around, they're doing something. So this is at a sensitivity of 7. I want to show you what happens when I change that sensitivity to 15. If you look here, that was not an arousal. We have got spikes, we've got slow waves, we've got evolution, we've got the length. This was a full-blown seizure. My techs did not pick it up at first because they don't, sleep techs don't always think to change that to look for seizures, especially if the patient is not a seizure patient coming to us. They brought it up to me because they were concerned because they kept seeing arousals all night long. And so when I got to dig in and really look at it, I started changing things around, and we discovered this patient now has been working with neurology for a couple months. We're going to get into something real fun next. We are going to start to see some videos. So I've told you these can present in very different ways. I'm going to show you what some of those presentations are. All right, so forewarning, some of these can be kind of hard to watch. I do like to give everybody a heads up on that. We're just going to watch for a little bit. So he's on his CPAP. If I remember right, he does not have any wires on. He might, but I can't. It looks like it's just his CPAP and hose. We're looking at the child. See those kind of choppy movements, and you hear that voice? This is his seizure. This is how it's presenting. Right there is a really good tell how he's pushing those arms out like that. But to a parent, to someone else, this could just look like they're having a nightmare, or they're just moving all over in their sleep, because kids do that. We know kids sleep in the weirdest ways. And then he came down. I'll go through some more typical and some atypical ones. So this is going to be what most generalized seizures will appear like. You can see that rhythmicity in how he is having his seizure. Very tense. Like I said, it can be very hard to see. Drooling, bubbles, keeping him on his side, that's the best way to do it. You never want to put anything in anyone's mouth. We'll go over safety stuff here in a little bit. Now he's relaxing. He's not shaking anymore. He's going to start coming down. He's probably still having discharges because you can see him staring. Once he were to fully come out of that, he would be blinking, confused, tired. So here's another one. Again, this, if anybody doesn't want to watch, these can be hard to see. He is more tonic than anything, which means he's very tight and muscly. A lot of patients tend to turn their head one way or the other. Slowly coming down. I always like to tell people too, if someone is having a seizure, don't try to move their arms or hold them down. That you're just going to hurt them and yourself. Just keep them as safe as you can. He's still having some seizure going on here. He's still not come fully out of it. I'm going to show you a few different ones now. This patient always sleeps in the crib. She's a snorer. So we're just going to watch her. You're going to see some interesting movements. So she's doing that arm movement and unable to understand, kind of mumbled speech. Those were her seizures. That is what it presented like physically. She is known to have multiple types of seizures. That's probably more associated with just a discharge. So that would be more of a jerk or a bird going on. And then she's doing it again and again. And she does this all night long. You can only imagine how tired someone is after doing something like that. This one is a teenager. And they're seizing right now. This is how they're presenting. And that could look like REM behavior, could look like sleepwalking. These presentations can be very unique. And if you don't know they can be, you don't know what you don't know. So having some awareness to this can be extremely helpful. I know in that poll, some people stated they have had people, most people, majority, had seen seizures in their sleep labs. I'm wondering how many have been missed. You know, I mean, not that you mean to miss. No one ever means to miss these things, but if you don't know. So raising awareness of seizures in sleep, I think, is extremely important. All right. So now let's talk about what do you do? There's three main parts. We're going to talk history, safety, documentation. History is so important, especially if you have a patient coming in, they have known epilepsy. There's some questions you need to have for that patient. What do your seizures present like? If you are still having seizures, or if you are to have one, what's your plan of action? So is there a medication that you need to take? Do I need to do something? Do we need to call 911 right away? And then let the patient know if they do go into a status epilepticus, which means they are having a seizure that's lasting at least 5 minutes, we're calling 911, or we're getting them to the ED, or whatever your policy is for handling patients that need medical assistance. That is it. Because if we go past 5 minutes, that seizure is not going to stop without medical intervention. Safety is the biggest one. Well, all of this is the biggest one. So for safety, like I said, 5 minutes, or if they're having 3 consecutive seizures in a row without 10 seconds of a break in between, they're going to need medical assistance. It's just the same as going into status. So best thing you can do is roll your patient to the left. The reason that you roll to the left is it keeps the stomach lower, so it keeps them from regurgitating anything, and it also helps with oxygenation. Do not stink anything in their mouths. I've seen videos like from back in like the 90s where they put a belt or a piece of wood in their mouths. If they're going to bite through it, they're going to bite through it. That's why a lot of seizure patients bite their tongues. I know a lot of questionnaires for patients that I review. One of the questions is, do you bite your tongue in your sleep? That is actually a tell more for seizures than it is for anything sleep related. Watching times. You need to be as precise as you can be with when they started their seizure to get to that 5 minutes. We're lucky that everything we're doing, if they're hooked up, is recorded. So that is time stamped right there for you. Make sure you can relay that information to EMS or whoever comes to get the patient. If a seizure lasts less than 5 minutes with no known history, you need to alert the patient. You need to do a level of consciousness. So ask them, do you know where you are? Do you know this? Do you know that? And then follow your facility's protocol. With ours, if the patient would like to continue after having one, we will continue. If the patient would like to go to the ER, we'll get them taken care of, whatever the patient wants at that point. If it lasts more than 5 minutes, they are going to the ED no matter what. Documentation. So things that EMS will ask, things that are good to have documented for you at the time of the event. When did it start? The duration, how long did it last? And then what did they present like? Sometimes they might be covered so we can't see, or there's a bunch of people in the room, so someone's standing in front of the camera on accident. Making sure you can document what they were presenting like. Were they shaking? Were they walking around? Were they talking? Were they screaming? Make sure you are marking in the study as well. If there's 2 people and someone can mark in the study while one is in the room keeping them safe, that's perfect, just so that way both are being documented. And note any action taken. If the patient did have a plan and they have someone there with them and they do administer some kind of medication, making sure we are documenting that. And then if applicable, anytime something like that happens in our lab, we fill out a safe event report just to make sure it is documented in their facility. We make notes in the system, and we make sure that that study gets read within the next 24 hours so the doctor can make determinations. Most of the time, my doctor, if I need this read right away, they read it right away, and we get everything figured out. We have reached the end of my presentation, everybody.